Hello. Today we're talking about something fundamental, something we, as physical therapists, see every single day. We are talking about the foot and ankle. Think of the foot and ankle complex as the foundation of a house. If the foundation has a crack or isn't level, it doesn't just affect the basement. It affects the walls, the windows, and even the roof. The rest of the body is no different. A problem in the foot can create issues all the way up the kinetic chain, leading to knee pain, hip trouble, or even back problems. Understanding this foundation is essential for effective patient care and long-term solutions. So, why focus so heavily on this area? Because every step a person takes begins here. The foot and ankle are marvels of engineering, designed to absorb shock, adapt to uneven surfaces, and propel us forward. First up is a condition we see all the time: plantar fasciitis. Think of the plantar fascia as a thick, bowstring-like band on the bottom of the foot, running from your heel to your toes. Its job is to support the arch and absorb shock. When this band gets irritated and inflamed, usually from overuse or improper footwear, you get plantar fasciitis. The classic sign is stabbing heel pain, worst with the first steps in the morning or after rest. Next, lateral ankle sprains, common in outpatients. The foot rolls inward, stretching or tearing the lateral ligaments. A wrong step overstretches the ligaments, causing pain, swelling, and instability. Without proper rehab, it can lead to chronic ankle instability and higher risk of future sprains. It's our job to prevent that cycle. Pes planus, or flat feet, is a flattened medial arch with more sole contact. It can be congenital or acquired over time, causing foot, ankle, and leg pain as alignment changes. Finally, Achilles tendinopathy. The Achilles connects calf muscles to the heel, crucial for walking, running, and jumping. Tendinopathy is degenerative, not just inflammatory. Patients report pain, stiffness, and sometimes swelling along the back of the heel, especially in the morning or after activity. Limited push-off makes every step a challenge. Plantar fasciitis. Pain avoidance leads to reduced heel strike, midfoot or forefoot landing, shorter stride, less stance time, and antalgic limp. Lateral ankle sprain. Pain and instability cause a rigid protective foot, reduced heel-toe roll, guarded gait with slight turnout, avoiding normal ankle motion. Pes planus. Excessive pronation, heel angling inward, arch collapse, inward leg rotation, stressing ankle, knee, and hip. Achilles tendinopathy. Weak, hesitant toe off, shorter steps, compensation with hip flexors. Developing a PT's eye for gait is practice-based. You don't need fancy equipment. Focused observation is best. Have the patient walk toward you, away from you, then from the side. Look for asymmetry, arm swing, foot turnout, and uneven head bob. From behind, watch the heels. Do they stay vertical or roll inward excessively? This is key for spotting overpronation and flat feet. Watch calf contraction at push-off. Reduced contraction can indicate Achilles weakness. Check pelvis level. A dropping side suggests a Trendelenburg sign and hip weakness. Front view, heel strike versus flat toe landing for heel pain. Watch knees for valgus, often linked to foot overpronation. Side view, shortened stance time equals antalgic gait. Count rhythm, absent push-off signals, Achilles or calf weakness. Sarah, 45 runner, classic right heel plantar fasciitis. Rhythm is off, left has a normal heel thump, right is softer, midfoot landing, shorter stride, reduced stance, textbook antalgic gait. Pain mostly gone, ankle feels off. From behind, right foot turned out 15 degrees to avoid rolling. Toward you, lands lateral border, slowly lowers, guarded pronation and stability. Walking away, left heel angles inward. Arch flattens, significant overpronation. Toward you, left knee dives inward each step. No limp but repetitive stress drives overuse. Side view tells the story. Right leg shows strong push-off. Left shows minimal plantar flexion. She substitutes with hip flexion to swing, yielding shorter left step. Gait is a vital sign, like blood pressure and heart rate, revealing compensation, weakness, pain, and instability. Mastering gait analysis moves us from treating foot pain symptoms to addressing root causes, the mark of a great therapist. Big takeaways. First, always look at gait. In a busy clinic, it's easy to skip. Do not fall into this trap. Make walking your routine, back, front, and side views. Second, connect the dots up the kinetic chain. Foot issues affect the knee, hip, and back. Overpronation? Check knee valgus and hip strength. Lack of push-off? Assess for Achilles, calf deficits, and hip flexor overuse. Address the foot and the compensations. PF needs gait retraining. Ankle sprains need balance and proprioception. Restore symmetrical, efficient, resilient gait. That is the foundation of great physical therapy.